Ladies and gentlemen, thank you for tuning in to another episode of the Nutrition Hero Podcast. This is Dr. Brad Watts. Thanks for being here and coming along for the ride today. Today we are going to be talking about some laboratory technology that is changing the way that we practice functional medicine, clinical nutrition, and gives us some information, some insight that we didn't have previously. So we're going to get into that. I'm excited about it. Maybe we'll nerd out a little bit about some of the aspects of this technology that your patients, I think, are even going to find cool. So if you're like me, you started in the clinical nutrition world, the functional medicine world, and spent a lot of time having people drool into tubes. And I smile at that, but testing adrenal glands through basically saliva. And so this adrenal stress index testing has allowed you to help a ton of different patients along the way, and it served its purpose. And one of the things I'm excited about is that technology has been improved upon. And we're going to get into this here today, but suffice to say that functional medicine world will never be the same once you switch your approach to measuring hormones. So what we're talking about today is from a company called Precision Analytical Incorporated, and they have something called a Dutch test. It's called Dried Urine Test for Comprehensive Hormones. Dutch test. And this Dutch test, I have been finding fascinating results with it. It's like seeing hormones in color rather than a snapshot in time, or it's kind of like having a video rather than a picture. And maybe that's a better visualization for you with it, but it's pretty amazing. I gotta say, I have looked at thousands and thousands of saliva tests over the years, and I've been able to help a lot of people with them. But what's interesting is this Dutch test and the explanations that go with it by the company, who I'm not affiliated with, by the way, but the explanations that go with it are phenomenal. I don't think I've ever seen anything like it. And so I've been able to participate in these tests a little bit more frequently here, and they're awesome, I have to say. So you can find out more information about it at dutchtest.com, D-U-T-C-H test.com. And we're going to talk about some of the application principles today that I have found to be staggering when it comes to reading your patient's chemistry. So the traditional saliva test, we're looking at our daily free cortisol pattern, so maybe we'll just start out with the adrenal gland testing here. And it's no different in the Dutch test. However, we're not just measuring the free cortisol, we're also measuring the metabolites. And that is critical information that we can utilize to figure out what's happening from a physiology standpoint for our patients. And so if we look at daily free cortisol pattern, typically you're going to see a lower waking and then elevated in the morning, afternoon, and evening. Well, on our saliva test, we would start out high and then trickle down throughout the day. The urine testing is a little bit different in that we're looking for the spike of cortisol. That spike of cortisol. And the spike of cortisol is interesting as it relates to people that are going through depression, people that are on antidepressant medications, and gives you some background, some information that will be able to help them accordingly. So anyway, instead of a high to low, we start low, then go high with the Dutch testing. And that spike from low to high is pretty telling as to symptomology for our patient base. So so that you can visualize this here, this low to high and then back down like a traditional saliva test would look. Now, when we look at our 24-hour free cortisol reading, it's going to give us a score. And one of the things that's cool about this Dutch test is it gives us a score on like a dial. So it looks like a speedometer kind of. And it gives us our laboratory range and whether the patient is in or out of the lab range from a 24-hour free cortisol reading. It's pretty cool. Now, when we look at cortisol metabolism, metabolized cortisol, so it gives us an opportunity to look at the total cortisol production, right? So it's total cortisol production. And so let's say we have low 24-hour free cortisol, but normal or elevated metabolized cortisol. What that would typically look like on an adrenal stress index testing would be that this patient has adrenal fatigue. Let's throw in low DHEA on top of it as well. that would mean that this patient is looking like an adrenal hypofunction situation on a typical adrenal stress index saliva testing. What the Dutch test shows is that even though the 24-hour cortisol might be low, their total amount of cortisol is high normal. This is just a potential patient case here for you. Now, why this is so cool is because obesity will cause a patient to sequester cortisol. Obesity causes a patient to sequester cortisol, which basically means that you're making your saliva test, your adrenal saliva test, look like adrenal fatigue, even though the body is producing mass amounts of cortisol. Okay, this also happens in patients, not just obese, but also happens in patients that have hyperthyroidism. Maybe patients that are getting dosed basically too heavy-handed with thyroid medication or thyroid supplementation. And so what happens is we don't, in a typical setting with a saliva panel, we're not looking at this metabolized cortisol value, and we can't tell what the total production looks like. This is amazing. And the reason that I think this is so amazing is because, in my estimation, from a functional perspective, from a nutrition perspective, across the entire country, there have been thousands and thousands and thousands of people treated for adrenal stress, like adrenal hypofunction, or adrenal fatigue, or burned out adrenals, whatever you want to call them. And my question is what percentage of them were treated incorrectly because we didn't know about, or nobody looked at, this metabolized cortisol? And so this testing is not necessarily new. It's based off of some standards that are, well, moderately old here, moderately experienced. But the delivery mechanism for this testing is something that the industry as a whole, I think, is going to be better served by. So this is really interesting to me because not only can you see the free, you can also see the metabolized, which gives you a picture of the total amount that's present. Okay, that is cool. Not only this, but this Dutch test allows us to, I wish I would have invented this, by the way. This Dutch test allows us to see the transition from cortisol to cortisone. Cortisol is active, kind of like thyroid hormone has active and inactive. Okay, so T4 and T3, or reverse that, T3 is active. Same thing here with adrenal gland hormone. Cortisol is active, cortisone being the inactive. Well, if your patient has low cortisol but high cortisone, what that's essentially doing is you're not going to be able to measure that from a saliva panel perspective, but what that's essentially doing is the body is down-regulating the action of cortisol. And what are the actions of cortisol? Right? Number one, gluconeogenesis, breaking down protein and fat into metabolites that we're using to basically create glucose, most of the time in the liver. And it also, that's the first action. The second action is we're looking at an anti-inflammatory pathway. So anti-inflammatory pathway, consider that more of like a rest and digest situation normally, right? There are extenuating circumstances that can cause that to be in a fight or flight context as well. However, in this instance, if we're looking at a patient that is funding cortisone, which is inactive, and so you're measuring cortisol, if they don't want gluconeogenesis, if we don't want tissue breakdown, that patient is going to look like they have adrenal fatigue. And then what do? Give them adaptogenic formulation and then something that increases the half-life of cortisol in the body, and we put the pedal to the metal on that, and this patient is basically being overrun with cortisol, and we end up in a spot where they start packing it away. Where are they packing it? Well, we get the prototypical buffalo hump on the back of the neck, top of the thoracic spine, and then the belly. The belly gets bigger. So not to mention different patterns of anxiety, ups and downs, sometimes people dealing with bipolar issues that are gas on a fire when we have a fight or flight mechanism. So in all of this, right, this Dutch test allows you to see what your body, not just what you're making for cortisol, but what you're doing with it. It's stunning. It's stunning. And so this is important because if you had a weight loss patient and they come in and their adrenal glands look like they're under functioning, and the patient's like, hey, Dr. Brad, how come I can't lose any weight? Right? Like, I'm barely eating anything. I'm eating meat and vegetables. I'm taking all of your supplementation and all of these creams and stuff that increase the half-life of cortisol. And I look at their tests and I go, well, it's because you have adrenal fatigue, adrenal hypofunction. And what if they don't? Right? This is what I'm saying. This is, so some of your patients that are out that are not getting better, some of the patients that are out there that are tough weight loss cases where you're just looking at them like, what in the world? You must be cheating. Right? Like maybe they have a Snickers habit they're not telling you about. Dutch test is what I'm saying. This is next generation hormone testing. It is phenomenal. So not only are we looking at the adrenal gland hormones, and again, I can talk about this for a really long time if you want, but it's exciting. It's exciting. So not only are we talking about the adrenal gland hormones, like I was saying, but we also get to talk about pregnenolone and where pregnenolone goes into DHEA, creating DHEAS, like a sulfonated one, but also androstenedione into testosterone. We're looking at the androgenic pathways, right? So one of the things that's important is not just what these values are, but we also want to see what the metabolites are like. The metabolic pathways of these hormones, estrogens and androgens, are extremely important. So everybody knows that if somebody has had breast cancer or some type of uterine cancer, you don't put them on estrogenic replacement therapy, right? But what happens is not many clinics around the country right now are actually looking at the metabolites that are telling you about the patient's detoxification pathways. So there's two phases to the detoxification here with estrogen that I want to talk about. The first phase of estrogen detoxification is more of like a hydroxylation process, and meaning you're adding an OH group to the chemical. And so there's 3 pathways for this. So this is phase 1 with 3 different pathways. So let's say we're looking at estradiol on a typical saliva test, and that estradiol value, let's say, is elevated for a lady. Okay? Well, if it's elevated and we're in an estrogen dominant situation, what we want to know is that a problem or not, right? Yes, we can have estrogen resistance and that type of thing where you can have a ton of symptoms associated with it, but what we really want to know is that lady at risk for funding and fueling cancer? Is that something that we need to get animated about? And so estradiol is actually metabolized by basically turning into estrone or estriol, E1 or E3, and we'll just go with the E1 pathway here for a moment. And let's say E1 now, we're going to go through this phase 1 of estrogen metabolism, these 3 different hydroxyl pathways. So they're called 16-hydroxyl, 4-hydroxyl, and 2-hydroxyl. 16, 4, and 2. 16, right? 16 is a more potent metabolite of estrogen. 4 is the quinone, the reactive, the cancer-causing or cancer-funding metabolite, okay? And 2 is the one that we want. 2 is the one that is going to be leaving the body, all right, through methylation. That's what we want, all right? So the percentages of these pathways that we desire to see, about 70, 10, and 20, okay? So 2, 4, and 16, 70, 10, and 20% of the estrogen values we would like to see appropriated accordingly. Now, with this in mind, if we look at estrone, and then underneath estrone, just draw 3 different arrows to go into 3 different metabolites with these 16, 4, and 2-hydroxyl metabolites. If we see a patient that is funding the 4-hydroxyl metabolite, which is the quinone situation, the one that's going to be promoting or basically promoting cancer, we want to make sure that we see that. If the patient is taking estrogen replacement therapy because they have hot flashes and then yet they are predisposed to detoxing in this quinone producing pathway, we're going to want to make sure that we change that. And how we change that are with support mechanisms like DIM, or basically supporting methylation like it's going out of style. Okay, so this is important. So if we look at the parent chemicals, estrone, estradiol, and estriol, and then we look at their metabolites, that allows us to figure out what breakdown pathway your patient genetically favors. This is so cool. You cannot see this in a saliva test. Now, When we figure out what pathway they're favoring, right, if it's not appropriate, if it's not desirable, we can give them support mechanisms to change it. That's the cool part. We can actually see that. So let's pretend, though, all right, let's pretend everything's awesome, funneling into estrone, so estradiol into estrone into the 2-hydroxyl metabolic pathway, which is what we want, all right, the one that's getting set up for methylation. And let's say that the levels are normal. So estrone's normal, and our 2-hydroxyl pathway here is normal. And then it looks like we have low methylation. Okay? What this is showing then is that we are not getting rid of this estrogen. The patient's not metabolizing it up and out of the body. If we don't metabolize these estrogens, where do they go? Okay? If we can measure the amount into the first chemical breakdown, remember there's 2 phases to estrogen metabolism. If we can measure the parent chemical estrone, estradiol, estrone, into the 2-hydroxy metabolism, that's the first step. If both of those are normal, but the second step, the second phase of estrogen metabolism is methylation, if the methylation's low, what's happening? This patient is harboring estrogen. They are not only estrogen dominant, as the test is going to show, they're harboring it, and it's fat soluble, right? Fat soluble. That's going to be a problem, a huge problem, right? That's going to be a huge problem. And what happens when hormone that's fat soluble gets left in fat cells? Well, it's like a water balloon. More water in the balloon, and it just gets bigger. Same thing with the fat cell. So we got more hormone that hasn't been hydroxylated. It's just going to be in a fat cell, and it's going to make that cell bigger. So we end up in a situation where the patient is gaining weight because they're just packing hormone away. Well, that's kind of crazy. Okay, that's kind of crazy. So, but how many patients are dealing with it because we don't have any capacity to look at their methylation levels? This is, man, I keep saying this, but this is so cool. Okay, so we can look at the parent chemical. We can look at the 2 different steps in the detoxification or the metabolism of estrogen. And if the parent chemical is building up, but the metabolic steps are on the low end, we know they're harboring hormone. Whatever they're putting in, they're just storing. Okay, same thing with the testosterone situation, same deal. Right, you got a lady with androgenic dominant situation taking place, and she's not getting better. Well, it's going to be important that we figure out why. Like if she's funding the DHT pathway, right? If she's funding DHT pathway, well, it's 3 times stronger than testosterone, so she's going to have a mechanism put into place where we can support detoxification out some other pathway. Okay, so this is very cool. Blending this with genetic testing, I think is going to be the future of how to help people from this perspective. So it's pretty sweet. Anyway, one of the things that you'll find on the Dutch test, and for those of you that are astute, you're going to bring this question up, so I'm just going to answer it right away. Progesterone. We measure progesterone, but progesterone's not in the urine. Okay, progesterone's not in the urine, but its metabolites are. So what the lab essentially did is they put a correlation together where they can measure the metabolites and give you a serum equivalent of progesterone. You can measure the metabolites and give you a serum equivalent. Well, that's pretty cool. So that's something that is on here as well, as far as us being able to apply this to our patient base. Now, when we look at all of these different metabolites, and we look at cortisol, cortisone, we look at estrogen, and then the hydroxyl forms of estrogen, it's pretty sweet. We can also look at nutritional markers if you like. Okay, organic acids. So this is blending some of the stuff we've talked about together previously with organic acid testing. This is blending it in as well, whether we be looking for vitamin B6 or glutathione, epinephrine, norepinephrine, that type of stuff. Melatonin. What about oxidative stress or DNA damaged? That's something that's pretty helpful as well. And so we can see these things in great detail all through this one test. Now, another thing that I appreciate about this is that it's the tough cases that in your mind, or at least in my mind, the tough case is sometimes somebody will go through care for 60, 70 days and they're not improving as fast as you would like them to, right? The applications for that type of a patient with this detailed of a test are phenomenal. They give us an ability that we didn't have before, and it allows us to further customize their treatment regimen. It allows us to further customize it based on their unique biomarkers rather than the diagnostic situation that they've had before they come into your office. And so I appreciate what these guys are doing with this. I appreciate the technology, but then also just the amount of research that's gone into it. The amount of research that you can stand on as a provider, knowing that, well, it's been tested and retested 1,000 times, knowing that the data that all of this is standing on is solid. And that's pretty phenomenal. So anyway, get on their website, right? DutchTest.com. Watch some of the videos. Get it in your practice. Your functional medicine, clinical nutrition practice is never going to be the same. It's changing the game. I'm telling you, don't get left behind in this, because I would imagine that if there's a standard of care in functional medicine, right, which there isn't obviously, but because of the art side of it, but if there is a standard of care in functional medicine, I'd strongly push for this technology to be part of it. So, all right. That's what I have for you here today on quick podcast episode regarding Dutch testing in preparation for what's coming up next. Hope you enjoyed it. Watch some of their videos, dig in, and get on it. All right. Have a blessed day, everybody.